Can we move on to the next one? Surgical strike and secondary angle closure by Dr. MITHUN PAI. Dr. MITHUN PAI is a senior consultant at MITHUN AIOC Hospital in Rajajinagar, Bangalore. Over to you, Dr. MITHUN.
Well, my topic is in continuation with Dr. Monica's. Basically, it's a surgical strike on acute rise in intraocular pressure during cataract surgery. The case being secondary angle closure glaucoma, more specifically phacomorphic glaucoma. As we all know, cataract surgery itself presents us with a lot of challenges in the form of mature cataract, hypermature brown and small pupils. Then there are the complications such as zonular dialysis and PCRs, which we tend to gain expertise over a period of years and tend to complete it in a span of, say, just 5 minutes. But significant number of cataract surgeries are associated with what is called, sometimes surgeons term it as severe positive pressure, that is raised intraocular pressure. Of course, Dr. Monica has spoken on the pre-op and post-op management, that is by oral acetazolamide, oral glycerol, or giving IV mannitol pre-operatively. But intraoperative raised intraocular pressure is a completely different challenge for the surgeon. Now, what are the cases which are predisposed to this kind of scenario? Mainly lens-induced glaucoma, in which phacomorphic glaucoma is a notorious one. Then any kind of angle closure glaucoma, be it primary or secondary, which have very shallow ACs. Also high hypermetropia and nanophthalmos can result in this kind of scenario. Unfortunately and sadly, even a normal case when taken can go up for this kind of scenario. For example, if the block doctor has given a block and not given enough pressure, you can face this kind of situation. Now, what is the clinical presentation of a severe positive pressure? The eyeball is extremely tense. It's also termed stony hard. Anterior chamber is not only shallow but extremely shallow and not responding to visco. Even if we put visco, it keeps coming out. And then there is the iris prolapse from a very well constructed wound. How do we manage such kind of situations intraoperatively? If rhexis is not done at all, then we have the option of postponing the surgery, put it on somebody else, or take it up on some other day when your luck is good. And if the rhexis is done, then we have no other option. We have to go ahead with the surgery. There are many surgeons who do many things. They try to loosen the speculum, they lower the BSS bottle. Many surgeons give intraoperative IV mannitol, waiting for about 30 minutes and then restart the surgery. But further management and outcome purely depends on the skill of the surgeon. When this complication occurs and anybody sees the surgeon, the skill of the surgeon is at display. You will know how good the surgeon is in handling this kind of scenario. But the final result, what we want, normal surgery with the intraocular in situ, is very, very rare. Every step is a struggle and every complication is possible. And what is possible? Starting from the initial step, there is iris prolapse from basically every wound. Then the iris viability is lost in a few minutes. There may be iridodialysis. Rhexis doing is almost impossible. It just goes away. Then nucleus delivery techniques all are very difficult, either SICS or phaco. There may be zonular dialysis. Then invariably, if it's a big nucleus, we'll strip the Decimet's membrane. But what is the eventual outcome? The usual final outcome will be a posterior capsular rent, which leads to a visual vitreous loss, and we do a vitrectomy. Now, this is the time where there is an actual decrease in the intraocular pressure, and then there is deepening of AC. At this point, if one is lucky, then everything goes on well, and if all the structures are there, we'll be able to put some sort of lens. But if your luck is bad on that day, either it can lead to a suprachoroidal hemorrhage or an expulsive hemorrhage. Few unique points about this scenario is, one thing is it's very rare. That is, it may occur once in 6 months or one in a year. So therefore, the surgeon is never comfortable handling this kind of situation, because all other complications he'll be handling very fast. There will always be a sinking feeling that, what you feel when you are a very junior surgeon, that something bad is going to happen next. Every possible complication mentioned in the textbooks can occur with this kind of scenario. All the structures from anterior to posterior are damaged. And unfortunately, vision pre-op is good in many of the patients. And post-op possibility of visual rehabilitation of such patients is severely compromised. Therefore, there is a need for a surgical strike in this kind of situation. A strike which reduces the intraocular pressure and deepens the AC. A strike which allows us to proceed with cataract surgery in the routine way what we are comfortable with. A strike which does not compromise with the integrity of the PC in any way. So what is that strike? This is the video. Sorry. Yeah, this is a case of phacomorphic glaucoma where we have taken up for surgery. We have done the side ports, but as soon as we do, there is a tense feeling. You know, whatever we do, even the visco is coming out rapidly, and even the iris starts coming out. We know that there is something wrong. Hence, we plan a surgical strike immediately, and this is that surgical strike. Basically, a 25 gauge trocar cannula is introduced transconjunctivally, and then the cannula itself is left in place. Here we have to use a vitrector. As soon as we put the cannula, there is egress of the vitreous through the cannula. Initially, vitrectomy can be done only at the hub of the cannula, need not go inside, but then we have to keep judging the deepening of the AC. If we are comfortable, then we try to start the case again. But during the surgery, if the anterior chamber again becomes shallow and tense and hard, then again we can repeat the vitrectomy as the cannula will be in place. Initially, it is a block of mindset, but then later it is quite easy to do. Again, at the hub we can do, or go deep inside and do a little bit of vitrectomy. And then once the AC is quite deepened, it behaves as a very normal surgery again. And then continue with the way we want to complete the surgery. Advantages of this kind of surgical strike: there is a very slow posterior displacement of the lens. We wouldn't want a PCR to occur, then a vitrectomy, then this kind of scenario. And vitrectomy can be done multiple times through the cannula. There are other methods where surgeons practice. One is vitreous tap with needle aspiration. A greater chance of hemorrhage is there. Also pars plana vitrectomy, which is quite popular, but it needs a little bit of expertise. Of course, even with this procedure, risk of expulsive hemorrhage remains. So one has to gain little bit of expertise in this also. And finally, thank you. Thank you to my teachers, Dr. Sirish and Dr. Malik, and to my colleagues who have helped me in this presentation.
Thank you so much, Dr. Mithun. Indeed, it was a very nice one. Dr. Mithun had come to the conference for an emergency. He had to fly out to Bangalore and then come back again only for this talk. And I'm sure it was worth every minute of what he spoke. He made that long travel. Thank you so much for that.
So this complications happens not always, but once in a while it happens. So patients, older patients, those are atherosclerosis, and all those patients are more prone for this. And loose journals, as I mentioned, loose journals, and when you do hydro, the fluid escapes into the anterivitreous. Identifying it as early as possible is very important. But sometimes you don't have to do a vitrectomy. You just, if you don't have trocar and all, you just put a needle there. Major 3 millimeter, put needle, just aspirate. You should be just below the lens and just aspirate some fluid. You don't have to. That itself can deepen it. And if
also done that, the needle, it works quite well.
yes, it works.
Yes, but as he has explained, the chance of retinal post-operative retinal detachment is high because you are
Actually,
pulling
we
the
haven't seen
vitreous.
it, but now
Yeah.
I think about it.
But I think the process which he has shown is probably better.
This
But
is
will
better.
it be easier to use a valve trocar and do a core vitrectomy, even not letting the vitreous to come out and cutting? So in that case, chance of pulling
Yes, sir,
vitreous is
definitely.
more.
Definitely.
And
This is a non-wired one.
direction of the cutter has to
Be very,
is
very important.
It has to be directed posteriorly rather than any angle.
Yes, sir,
No,
because-
sometimes what happens, the standalone surgeon, those who have a vitreous VR surgeon support, they can, I think
Like-
that's such a, either if it is very severe and you are not able to do anything, just close all the wounds, leave for 1 or 2 days, it might settle down.
It has happened to me once.
Which one?
25 gauge, sir. 25 gauge. If you have.
It has happened to me when I'm
Yeah.
doing the Rexis, and the shallowing of this, you can't even bring the forceps out.
Yes, yes.
It's touching, almost touching them.
Such time just-
It is now routinely happening even in normal NS2, sir, in camp setup. Earlier, our seniors used to call us and blast us. Why you have not given
So you
massage
are-
properly? Now we have
Now
stopped.
you are learn yourself, okay.
Now we have stopped.
I think keeping a trocar cannula in your clinic is not very expensive, and this is really a very nice demonstration, I would say, much better than, anything else.
It
pulling
can be
by
done
you.
even with interior and
Yeah.
vitrectomy cutter.
Yeah.
Did
And
you use IV9 or preoperative?
Yeah, we have used, but the pressure was a little high only, but we had no choice. We had to go with the surgery.
And was it case of phacomatous glaucoma?
Yes.
Did you plan a combined surgery?
But that
I
patient,
will always go. I'm sorry. I will always go.
no, patient was very frail, madam. Patient was quite frail. We didn't want to.
All of them are frail. By the time they get phacomatous glaucoma,
Yeah.
they're all
So
frail.
how long the glaucoma has been there, right?
Pressure is above
Yeah,
50.
it was-
The pus will only develop only after a certain duration.
Yes, phacomatous
We have a study of neglected 50 eyes with phacomatous glaucoma during pandemic. 1 month sitting at home. So I used to say, just PR. I used to say that this also may get knocked out if I do the surgery. Used to get luckily, all of them got 6/6 vision. So somebody was I cannot. It's not my surgery. It's something really,
No,
really
usually
bad.
phacolytic or phacomorphic, usually tackling the cataracts usually sorts the issue. Unless you have a documented proof it's been staying for a very long time, which is unlikely in especially these two
We
conditions.
had those OPD slips from primary health centers of 21 days. They said we thought your institute is closed. So these were the study of over 21 days.
But they had a pressure rise over this whole period. You had
See,
records of that?
initially in the primary health center, they wrote digitally hard. They gave Diamox, they took for 2 days, stayed at home. And then they said we didn't have, all kinds, this
No,
lockdown.
probably the pressure came down, they didn't have pain, that's why they
The
didn't.
pressure was 50 plus when they came to me. With this lockdown. They were very strong.
So many times, even if they have very high pressure, they don't come in. So they don't have a chance.
56 pressure.
Yeah, I think shall we go with the next talk because we
I think
may
we're falling
lose
short
time.
of time.
This has been a very nice session, sir.
I-
Thank you to all of you. That's really nice.
The main, I think, take-home message is you need to know what is the right thing to do at the right time. So right decision at the right time saves a lot of trouble.
And it has to
So
be
Ken,
case-based, that's.
yeah.